So I think we might go ahead and get started. I'm Leanne West, and I am the Chief Engineer of Pediatric Technology at Georgia Tech. And we are excited today to have Nick Yaitsky from Wellstar as our guest on our Ask the Experts. Is that what we call this? No, invited speaker series. We've got that. And also, before I let Nick start, Christopher is going to put a link into a pediatric event we are having in November. So I encourage people to sign up and join us. But Nick, I was wondering if you can give us a little introduction of yourself and maybe Wellstar, and then I'll let you get started on your talk about AI and healthcare.
Absolutely. Thanks so much, Leanne. First of all, I'm just absolutely excited to be here talking with you all. Georgia Tech is very much near and dear to my heart. Many years ago, I got my bachelor's at Georgia Tech and realized, one is not enough. So I went back and got a master's at Georgia Tech as well. So Georgia Tech has just been one of those things that is constant in my life. Let's put it that way. And I think all of my kids are wanting to go there as well eventually. So first and foremost, Leanne, thank you so much for inviting me to this. Just really thrilled to be here. And everyone that's listening in, thank you for joining us. I'm Nick Yaitsky. I am the Chief AI Officer at Wellstar Health System. I'm also the Head of Enterprise Architecture at Wellstar, so trying to wear a few different hats in that space. But I'm coming to you from the lens of AI itself. And, AI is one of those things that is probably permeating all walks of life these days. And so the term itself is getting a little bit overused. And so we're going to talk a little bit about what I mean when I say AI, just to make sure that we're level setting things. And we're going to talk about what we at Wellstar are doing with AI. What are some of those specific initiatives, some of the specific concepts? So really excited to jump into it. I'm seeing some of the invite list here, and I recognize a few names, so really excited about that as well. So thank you all for joining us. My big ask for everyone in the audience is, as we're talking through these things, post questions. Put up the questions. I want to have a bit of back and forth on these things because it's, I get tired of talking constantly. So please do ask questions. Let's have a dialogue about some of these things. And so jumping right into, first of all, I hope you all know who Wellstar is. Wellstar, we are one of, if not the largest healthcare systems here in Georgia, just depending on which day of the week you ask. But we have 11 hospitals at this point across middle and north Georgia for the most part. But we really cover approximately 1 in 6 Georgians come to a Wellstar facility for their healthcare. Which, Georgia is a massive state, as you know. I think we're the largest state east of the Mississippi. I think that's the metric. And we cover 1 in 6 Georgians. Fun fact that most people don't realize. So our largest hospital, Kennestone Hospital, just north of Atlanta, right? The emergency department at Kennestone is larger than most Georgia hospitals. Just the emergency department. It's about 160 beds in just the emergency department of that one hospital.
That's amazing.
That's massive, right? And just compared to the rest of the hospital, it's an absolutely massive facility. But also with that kind of scale comes a lot of complexity. Just to give another little tidbit there, that emergency department is also, I think, the 8th busiest in the nation. And that's by Becker's assessments. So it's just extremely busy. A lot of different things are going on, a lot of different initiatives going on. We are handling every type of service that you can possibly think of within that space. Once again, the complexity increases exponentially with size, with scope, the number of patients that we serve, the number of capabilities we offer there. Pediatric services within the emergency departments, pediatric services within the hospitals themselves. When we look at the Wellstar's breadth and footprint, Kennestone is the largest hospital, but we also have a very large hospital in Augusta. And the Augusta facility is both a main hospital, but also the Children's Hospital. And so the Children's Hospital of Georgia it's actually attached by a walkway between the main hospital and Children's Hospital. Absolutely fantastic location, fantastic facility, the kind of innovation they're doing in that space. It's very closely aligned with what Augusta University does. A lot of the physicians within that space are faculty from Augusta University. And the best part, I think, is that there's a Chick-fil-A on the first floor of the Children's Hospital of Georgia also. That's the best part right there. But Wellstar, we're growing, we're ever expanding. I think we have close to 2,000 physicians within our ecosystem. And so as we jump right into things, I think that you all being present here and listening to some of this conversation, I think you realize and you've already come to terms with the fact that AI is here and now. AI is not something that's eventual in the future, kind of, sort of, maybe, not quite sure what it is yet. AI is here. Every day, each and every single one of us, we touch AI in some way, shape, or form. We might not realize it sometimes, but we always use AI for all sorts of different things. Just about every single cell phone uses some sort of AI for a lot of different things, right? And so it's not something that we think about as a magical kind of ephemeral thing that's out there. It's a lot of different things. It's a lot of individual things. But what I think might not be as intuitive for most is the mindset that AI is not about making things more complex and more robotic. But in the context of healthcare, I'm a firm believer that AI is going to create a more human healthcare experience. And that's a lot of what we're going to talk about today, is how AI creates that mindset of it's not just simply technology and more technology upon more technology. It's about really moving technology away from being in front of you and being more behind the scenes, more embedded within your day-to-day, to where you don't even really think about it as technology per se necessarily. And so first and foremost, the big philosophical almost kind of question becomes, what is AI? Because everyone I talk to, I seem to talk to too many people these days, but everyone I ask, what is AI? Everyone has a different definition. There are textbook definitions, there are business definitions, but fundamentally, AI, once again, is not a singular thing. And so within Wellstar, we think about it in many different contexts. We think about it as different types of AIs, different types of solutions. AI is not a brand new thing. It didn't come to the surface when ChatGPT went live. That's not the first instance of AI. AI has been around us for decades in various forms, various shapes, right? It could be simple, it could be complex. And so we think about machine learning, we think about deep learning as kind of fundamental concepts. But once again, they're not overarching concepts. There are AI solutions that are not based on machine learning as well. I want us to think about that as well. Gen AI is the most talked about form of AI. But once again, it's not the only kind of AI out there. And so within Wellstar, we really think about the total gamut across all different types of AI, because different solutions require different kinds of capabilities. When you are day-to-day looking at different platforms, whether it's watching something on Netflix or driving a Tesla or working with a co-pilot of some sort, you're engaging with different AIs. You might not think of them as AI, like a recommendation engine for what to watch next, but they are still AI-based type of solutions. And so when I talk about AI, when I think of AI, I try to think of it as it's not about the human intelligence mindset. Usually when I ask the question of what is AI, people say, well, it's trying to emulate the human intelligence. I don't believe that artificial intelligence is emulating human intelligence. I've not seen an AI solution that does something the way a human does it or thinks about it the way a human does. I just don't see that happening. We try to explain it in human ways, but I don't think that's what's really happening or the way we're even thinking about it internally. And so I visualize AI as an AI solution is an agent, a machine, a robot, a software, an action that can understand where it is, deduce its environment, understand what it can do, and based on that, try to reach a goal, try to execute something. That could be through a chat conversation, through Copilot or a ChatGPT or something of the sort. It could be through a recommendation engine. It knows its goal is to recommend to you something that you will watch. Okay, what will be the most likely thing for you to watch? It could be part of, you're driving an autonomous vehicle or you're driving a vehicle with detection for cars around you. Its goal is to keep you on the road. Its goal is to get you where you're supposed to go. and what's going to maximize that goal. That's its action. It's not about the human intelligence. It's about driving to a destination, pardon the pun there, when you're dealing with that agent. And so in Wellstar, we think about it in many different ways. And the key that I want to stress is AI is another layer of automation. Once again, it's not a magical thing that solves all your problems automatically. It is another layer of automation. And when I say we, humans within healthcare, outside of healthcare, everywhere, has been doing automation for a long, long time, for many decades. Automation comes in many different forms. We traditionally talk about automation from an RPA standpoint. How do we automate clicking different links, automate different actions, repeating processes, very deterministic actions. Very much, I do this, I do this, I do this. I don't want to do it manually every time. I want to automate those processes. We talk about automation from developers that are writing code. They're doing test automation. I hope that developers are doing test automation and not testing everything manually. It's impossible to do so these days. But we've automated these things very frequently. APIs are always involved. We are working with chatbots. We've been working with chatbots before GPT went out, right? But they used to be a little more simplistic. And now we're automating them in a different way. The language becomes different. The language constructs, the responses, and the natural language processing becomes different. But it's still another layer on top of that. It's another type of automation within that same realm. Workflows, processes, these business processes, these things all get automated in one way, shape, or form. And machine learning is another method by which we can understand what's available, understand the data, understand the patterns, understand what can happen, and automate the results of that to then feed back into other loops, into other cycles. And all of these things come together. All these things are pieces of a puzzle that really help us with automating and expanding our services, our capabilities across the board. And I don't believe that's unique to healthcare. That's not unique to Wellstar either. That is, I think, a more general concept, but I can definitively tell you that within Wellstar, within healthcare, we do all these different things in many different areas because healthcare absolutely needs it. The complexity and the breadth of what all happens in healthcare is so drastic that if you don't tackle all these, you're going to be inundated and you're going to have to hire way too much staff and the cost will simply skyrocket out of control. And so when we talk about the promise of AI, AI is absolutely fantastic in many ways because it can do a lot of these automations, but we have to be very cautious about it. And so I'm fairly certain that every single healthcare system thinks of the governance and the risk associated with AI first and foremost. Before they even think about, well, it's going to solve my problem, the first thing they truly think about, dig deep into is, what are the problems that it will cause? How do I make sure that whatever I do is what's best for the patient, best for the provider, best for the team, best for the system? Because if I introduce a solution that could harm a patient, it's a no-go. It's not an option. Patient harm is not an option ever. And so we have to be very cognizant of that, very careful about that. Most AI solutions these days deal with data, large quantities of data. And healthcare data, I don't know if you've looked at healthcare data, but healthcare data is dirty. It is probably one of the dirtiest data sets that I can think of. Is just, it's coming from every which way. There is so much of it. It's expanding so rapidly. There are many who are trying to get it under control, getting it normalized, but it is hard. Bad data in results in bad data out. So whenever we're implementing machine learning solutions within the AI space to solve problems, if we don't account for bad data or biased data or incomplete data, we've got problems. We can't have these problems. We have to make sure that we're accounting for these things and we're solving these things before we get things into a live state. That also sometimes holds us back. Healthcare does not innovate rapidly, right? Healthcare is very cautious, very careful. And so we want to be sure that we're in a good standing before we actually move from a proof of concept to a production stance. So that causes a lot of things to hold in the proof of concept stage. Sometimes you don't get past proof of concept because it is questionable or risky. And we have to be very careful. A startup that is just a technology startup can throw up an AI solution and run with it and no problem, we'll figure out compliance later. Healthcare can't do that. You can't back into compliance in healthcare. You have to start there. You have to start with governance. And so that's how we think about it within Wellstar is AI governance is first and foremost. And AI governance is not a technology task. I want to stress that. AI governance is not about the technology itself. When we staffed our Center of Excellence to cover AI governance, about 15% of the people in that team are IT folks. Everybody else is from other areas, whether it's clinical risk or nursing practice or physician practice or compliance and legal and HR, ethics. All these different components all factor in. All these things have to come together to really understand what is the impact of an AI solution that we're introducing into the space. All these things have a voice, and they must have a voice, and they have to be at the table. You can't just simply say, well, the algorithm is sound within the Python script, so we're good to go, no problem, right? That's only the first step. Everything else has to be part of that equation in order to govern it successfully. Now the fun stuff. And so once we put our governance process together, once we put the framework together, the guardrails together, and we said, here are the ways by which we're going to make sure that we are safe. Now we can actually start to innovate. Now we can start to expand. And these are some of the focal areas that we're going to talk a little bit about today. We're going to dig deep into some of these areas and discuss about several solutions within each of these spaces. When we talk about innovation of AI for these areas, AI is not just present within one realm or another. It is across the board everywhere in healthcare, as I mentioned. Bedside, physician side, in the back office. If you could imagine how much back office processing happens for billing or validation or quality testing or all these different things, supply chain, it is massive. The footprint to support a hospital, even a singular hospital, is absolutely massive. And anywhere we can assist with automating these things, it's already a huge plus. And so to repeat one of the things that I mentioned at the beginning of this, as we start to dig into some of these, as I start to talk about some of these things, I want you all to ask questions. I want to see where your mind is, where you're thinking about some of these things, about have you explored some of these areas? Have you touched on some of these functionalities? And let's have that dialogue. But the first area we're going to dig into is the direct patient engagement space. So what is it that we do from an AI standpoint when we are talking directly to our patients one-on-one, or the patient is outreaching us perhaps? I think the most common thing that we all know and love I say sometimes facetiously, is when you come to a website and there's a chatbot on the website. Sometimes that chatbot can be fantastic. Usually it's pretty rudimentary and you're asking questions and it can't answer and you're going operator, right? You want someone to pick up the phone and talk to you directly. But chatbots have been evolving and growing. And so if you think back to way back in the day when COVID first started, right about 5 years ago, right? A little bit more than 5 years ago, 5.5 years ago now is when COVID really first started. Every single healthcare system that I can think of was scrambling to try and figure out what do we do. We got patients that are exhibiting symptoms, but do we bring them to the hospital? Do we not? Do we have them treat themselves at home, or what do we do? Because we don't want them to be sicker. We don't want to overwhelm the system, but we don't want the patients to pick up something else in the process. Because coming to a hospital doesn't necessarily fix just that one thing. Sometimes you can pick up infections. That happens, right? And so chatbots started coming out every which way, going, we're going to help you triage whether or not you should come to our ER or if you should stay home. I think healthcare systems started to adopt these things. They started to digitize more and more. They started going, how can we keep you out of the hospital more at that time? These days with Gen AI, we're supercharging what those chatbots can do. And so we have a project that is underway right now where we're trying to figure out, can we use a Gen AI enabled chatbot to help better schedule appointments? So there is complexity involved in a patient reaching out to a physician to actually book an appointment. So how do you connect the dots for which physician is going to help you with the specific thing that you're dealing with? If it's simple, okay, that's simple. But if it's more specific, if it's a very, I'm not a physician, I'm not a nurse, so I'm not going to go into the medical side of the house for that. I'm an engineer. But when you think about the minutia of I guess the finer points around orthopedic medicine, and you have a pain in your elbow, and you have a pain in your knee, or you have a pain in your hip, different specialists will treat different parts of the body, different conditions, different procedures. You've got to make sure you're aligning those to what the patient needs. Do we ask you 20 questions, or do we maybe assess your chart? Maybe look at what your background is, what your history is, and what your specific current symptoms are, and give you a more directed recommendation for what provider to see. How do we book the right appointment at the right slot, at the right time? Those are all things that we're embedding within a chatbot experience and trying to find the best way to engage you from that standpoint. We're embedding that within our call centers as well. And so the typical call center is when you call in and you have an IVR phone tree, right? You go through, press 1 for this, press 2 for that. The more innovative ones are simply saying, hey, talk to me with natural language. Ask me about questions, ask me different things. The more modern way, the next level of that is when that conversation results in action. So the basic one is 1, 2, 3, 4, 5, pick an option, and it sends you to the right agent. The more advanced one is tell me what you need to hear, what you want to hear about, and then I will route you to the right agent. The next one is I want to do X, Y, and Z. Okay, great. Let me do that for you. I want to refill a prescription. I want to schedule an appointment. I want to find out the status of my test results. I want to see my bill. I want to do this or that. I want to reset my password. Most of those things can be done in an automated fashion. And so we're using Gen AI especially in this space to really start to create that more action-oriented, agentic approach to performing these actions. And so we're expanding those across all of our call centers and working on what that comprehensive solution really looks like. Symptom checkers is one that I touched on a bit as well, right? Do you have COVID? Do you not have COVID? Should you go see an ER? Should you stay home? Symptom checkers are getting more complex as well and getting more innovative as well. The age-old joke around, well, I was feeling bad, so I Googled my symptoms, and I think I have Ebola. No, you don't have Ebola. You probably don't have Ebola. There's almost zero chance that you have Ebola unless you're a very specific subset of population. You don't have Ebola. But that's what I got from all these different sites that I read, because I have headaches and I have this and that and all these things. Symptom checkers need to be more specific, more purpose-driven, more action-oriented, the things that are more likely for you to have, as opposed to things that you probably almost certainly don't have and won't have. And so we're looking at how do we expand those and really connect those dots to the right provider as well. Because once again, if you have a problem, we want to connect you with who can actually treat that problem for you, right? Content search, content navigation. So how do we get you to the right information? You, let's say, got diagnosed with something. AI can start to, first of all, hydrate some information about content. So if we have documents that are very heavily clinical language content, so these are terms that the normal person, even myself, who's in the healthcare space, but once again, not a doctor, I see some of these terms and I go, I have no idea what that means. But we can use dictionaries of content, of clinical libraries. We can use generative AI in this context to translate from clinical language to human language, to the layperson's language, to something that we can actually understand and take action on. And so we're using those things to be able to find the right content and also find the right providers. What does this provider treat? Well, they treat a certain condition by a certain clinical name, but there's also a more common name for it. The canonical names like tennis elbow, right? I don't even know what the clinical name for tennis elbow is, but I'm sure it's not tennis elbow. Let's put it that way. Patient education is one that is very interesting. And we have a project that's in flight right now. We haven't solved this one yet, but we're thinking through how to solve this. And the problem space is this. If after you've been to your physician and you come back home, you usually get a stack of papers printed out for you at the doctor's office. How many have had that happen, right? Is you leave and you have a stack of papers, or you get an email with a document that's maybe 5 or 10 pages long, and it's your after visit summary. It's a whole bunch of content. How many of you actually read that? Personally, I know I'll scan the first page and throw the rest away, right? That's one of those things. So what's the point of sending that? Well, maybe it's regulation or compliance that says we have to send you this. But maybe we need to go deeper. Maybe we need to actually use that and deliver that information to you in a way that is more meaningful to you. So you as a patient, how can you receive that information and actually process it in a way that makes sense to you? So can we send you maybe little notices and tidbits? Maybe we can take that ADS, summarize it, and give you little blurbs about this, and this. Here are the 5 bullets you should think about. Here, you want to get more information? Great, go here. Here's more information for you if you want. But here is a summary. So you don't need to go through 10 pages. You just go through a few bullets or a few quick blurbs. Maybe we give you that information over time and use AI to really determine what is the best approach to reach you, personal you. Now, patient direct contact, patient direct action is not the only area, as I mentioned. Within the hospitals, there's a lot of opportunity, a lot of things that are being automated in many different ways. Patient fall detection is one of the things that I love talking about, because the innovation that I've been seeing in the past couple of years in the space has been absolutely. One of the initiatives that we have been spearheading at Wellstar is what we call the smart patient room. And you may have seen some news articles about that, but what that really means is within a room, you have, of course, your TV, and we have a large form TV. Above that TV, you have a camera kit, much like what I'm using right now for a meeting through Teams or through Zoom or any of those. And then off to the side, you also have a larger camera with pan tilt zoom and really good zoom, to where it can read your wristband from across the room, all the way across. And so what is that for? Well, one of the most common things that we implement through that is virtual nursing. Think of the idea of, instead of a nurse that is doing your admission or discharge or follow-up or education having to be on the floor, they can be remote. They could be at home. They could be somewhere in a centralized area, or they could be in a different hospital altogether. And they can do a digital knock into your room, come on screen, have that conversation with you. The concept seems simple, right? It's just like what we're doing right now. This is a virtual conversation. But applying that to the nursing setting, making sure it's the right nurse coming into the right patient with the right controls, with the right security. But is that all you can do with those cameras? No. So there's a vendor we're working with right now that we have set this up. We've set up virtual nursing capability at one of our hospitals, top to bottom. If you ever go out to Paulding Hospital, absolutely gorgeous hospital, gorgeous facility. I think we built it about 9 years ago is when I think the building was built. Absolutely amazing if you ever go there. Beautiful facility. Every single patient room now has virtual nursing enabled within that room. Every single room. And we are deploying pilot sites at many other hospitals at this time as we speak. I think we've got 3 pilots deployed already, and we're about to start deploying other pilots as well at other facilities. And we spent several years working through and making sure that we have the right approach for it. And now we're starting to expand the capability there. The vendor I mentioned in this space has edge computing on the cameras themselves that has AI models enabled within the cameras that can do things like fall detection. But to do fall detection, it has to do object detection. It has to understand what's going on in the room. And so the camera itself sees the patient in the bed. From that patient, it then creates a digital skeleton to understand where the patient is. It can even detect the patient under the bed sheets, under the covers, where the skeleton, there's certain limits for where your legs and arms can be when you are in the bed, but adjusting based on what it sees, based on the sheets that are on the bed. Now it can also detect when that skeleton starts to move. It can detect when the railing on the bed is down or up. Now you factor that in with your patient chart, and you look at it and go, okay, this patient is coming out of surgery. They're on medication that makes them drowsy, that makes them loopy. Maybe they are elderly. Maybe they are not quite present as to what's going on. what's the chance that they are edging towards the bed and they might fall out of bed? That is a very real problem. So for those who don't know the healthcare setting, what used to happen was hospitals would identify high risk patients and they would literally have a person come in and sit in the room and watch them, because we don't want that patient to fall out of bed. That could be detrimental to the patient, not to mention to what the hospital would face as a result of that, but to the patient themselves, that could be absolutely detrimental. That could be a killer potentially, right? And so they had a person literally sitting in the room watching the patient. As a result of digitization, especially during COVID, those people went virtual. They started using these cameras to watch the patients that are high-risk patients. You can't watch all of them, but the high-risk patients, to make sure they don't fall. With edge computing AI, it's now using that AI to detect those patients, watch the patients for you, and alert the nurse, hey, this patient is starting to move. You may want to go in and check on them. And the nurse to the room, make sure the patient's okay, put them back, put them at ease. If there's something down in the bed and it needs to be covered up, great, fantastic. Now, one thing that this vendor that I saw, we have not implemented this yet. We're thinking about doing this, but one of the capabilities that this solution also does that I absolutely loved is this skeleton that it draws. This is done on the edge, at the camera level. It's not the central server that's doing this work. It's actually done on the edge. The camera feed itself that's coming in, you can enable what's called privacy mode, where the patient disappears. So think about the case of, let's say the patient we're not talking about fall risk directly necessarily, but the patient is mobile, they can stand up and whatnot, they can walk around, maybe they're in some level of undress, and you don't want to, you want their privacy respected, you want them to feel, comfortable. And so you can literally enable privacy mode to where on the edge, that camera is detecting a skeleton and drawing the skeleton in the video feed. So the person watching, the telesitter watching, sees the skeleton walking around the room and not the actual patient's image. How amazing is that? I mean, that is a truly AI play that allows that kind of privacy that's presented there, that's made available. Another area that we're working through right now, and we're starting to pilot this at one of our hospitals, is robots. Everyone loves robots. If you know the way hospitals are laid out, usually there is a centralized pharmacy and depending on the size of the hospital, that pharmacy could be quite far away from a patient room. And so when a patient needs a certain medication, typically a nurse will call down to the pharmacy and say, hey, I'm ready for this or that. Or they might place it as a digital order, but still a process. Pharmacy gets it, they mix the medication, they fill it. Someone has to bring that medication to the room, and that could take a while. And so we're piloting robots that can actually do that delivery for us, whether it's medication or whether it's equipment, maybe tools, maybe some sort of scanners or something of the sort. And those robots are able to, someone is able to place the item within the robot. The robot can navigate the hallways and navigate elevators. That's a fun problem to solve. But be able to get to where it's trying to go and actually get to the nurse's station for a nurse to pick out that item from the robot and give it to the patient. So the nurse doesn't have to take time to go and chase down the medication or the tool. How much time does that save? How many hours a day for a singular unit even could that save for nursing staff overall? So this is something that we're piloting right now. We're not live with it yet, but it's something that we're looking at. And there are different concerns with it, and there are things that we're trying to mitigate these things. We want to be very safe with these things, right? There are sepsis in another area that is very important. There are several different predictors out there today for sepsis. The problem is that they all have issues in some way, shape, or form. And I'm not going to say which one is good or bad right now because there's a lot of different ones and it's debatable. But this is an area that is still doing a lot of research. And, sepsis is one of these that there are things that you want to look for, but really you want to alert ahead of time before something really bad happens. So the more lead time you have on that, the better off you are. And so that's really the main focus here is how do you create a prediction that doesn't have too many false positives? Because when you have too many false positives, what happens? We as humans, we start to ignore them, right? We're all human in this context. Well, most of us are human. And so physicians or nurses that are seeing alerts that are too many false positives, it starts to become just something that you brush off, but you can't brush it off. And so it becomes a problem if you don't have a very accurate model. So we're actively looking at different solutions in this space. We're actively researching these things. That leads to alarm fatigue. I don't know if any of you have had the opportunity to be a patient in the ICU. I was a patient in ICU about 2 years ago. I don't recommend it. Uh, my service was fantastic. The folks there were absolutely amazing. They saved my life, but I don't recommend anybody wanting to be a patient in an ICU setting. But in an ICU, the number of alarms, number of dings, bells, everything of the sort that goes off is absolutely overwhelming sometimes. It's overwhelming to the patient, to the family members that are there, and to the staff. Think about it. You're on your feet 12 hours a day, and you are hearing the alarms and bells for all the different rooms constantly. That's draining. That is overwhelming. And similarly, when there are too many alarms that are caution alarms that are not actual problem alarms, you start to kind of phase them out mentally. We don't want that, right? We don't want things to be ignored. We want things to be acted upon. And so we have a vendor in this mix that is in the ICU setting that's collecting all the telemetry feeds. So now we're talking about not sensing the rooms or anything of the sort. We're talking about telemetry feeds, real-time, time series-based data that's coming in. That is a lot of data, real-time flow. It's assessing the trends. It's doing prediction based on that specific patient in that specific room. Here's what their normal state is. And now we can see where their abnormal states are. How can we change the thresholds of those alarms to reduce the false positives based on the individual patient? How can we alert the staff for only those cases that actually need intervention specifically? So that's a very critical area of focus that we have. I'm going to touch very briefly on surgical augmentation because this one, this vendor came across that we recently assessed, and we are working on figuring out how to pilot this properly. But think of it this way. During a vascular surgery, you have x-rays that are happening during the surgery to make sure you know where you are in the body and you're actively performing the operation. This solution is taking those 2D images, real time, transforming them into 3D, and presenting them to the clinician at the point of surgery as they are traversing the human body in 3D. I haven't figured out the secret sauce behind the scenes yet, but something we're looking at because that's absolutely mind-blowing. That is taking those 2D images, it's converting it to 3D, it's giving the physician, the surgeon at that point in time, the ability to really navigate more accurately within the human body at that point in time. Disease prediction is one area where we are still having trouble, and I think everyone is having trouble. And so if any of you are researching anything in this space or you have contacts in the space, come talk to me, because this is an area that I think every single healthcare system is very interested in, and there are very few who do this well. Every healthcare system does some level of risk stratification, understanding high-risk patients, low-risk patients, potential risk patients, all those different things. But if you think about disease prediction itself, what is the likelihood that you as a patient will develop a certain condition over the course of the next 3, 6, 12 months? So we can preempt that, get you the care you need, and get you healthy without waiting for that condition to become late stage, right? How can we get ahead of it, make you healthy ahead of time? Huge area of focus within the AI space today. Now, of course, we have business process automation. How do we reduce the, I don't want to say mundane tasks, but a lot of the back office processes, the amount of work it takes to take a patient chart, to take the notes that physicians have documented for a given patient visit and pull codes out of it. If any of you have delved into clinical coding space, ICD-9s, 10s, CPT, DRG, you name it, right? SNOMED codes, so many different lexicons, so many different codes. It is literally people's full-time job to code charts. Literally full-time job to code charts. Why are we coding charts? Well, the key premise of coding charts is so that you have a very clear-cut, almost machine readable, basically, structure of what actually happened to a patient, what procedures they went through, what they've been diagnosed with, and how it was treated, right? We want that to be very methodical and very clear-cut so that machines can read it. Part of it is so that hospitals can get paid for the services that they've rendered, so they can go to the payers, so they can be back and forth with insurance, right? But part of it also is we want to use that to help predict the next things. We want to be able to use that to understand, did we overprescribe? Did we underprescribe? Did we manage the patient care properly? There are lots and lots of analyses that are done based on that. But the actual act of coding that chart is very, very time consuming. So there are numerous models that we are working with that automate some of these processes, taking a free-form clinical note that the physician has provided and be able to pull out the individual codes from that in an automated fashion to where the coder, this is the clinical coder, can simply scan through and go, yeah, that looks good. Or, yeah, but we should actually add this one or remove these two codes. That makes it better. But instead of having to start from zero, they have something to start from. And that truly speeds up that process. That also goes into insurance validation, insurance verification, and prior auth. I don't know how many of you know the process of what happens to get prior authorization to perform procedure. It's for basic things, yeah, not a problem. Physician prescribes it, you go do it, move on. Many insurance agencies do require approval from them before a procedure is done, because they're trying to make sure that they don't have to account for certain procedures to potentially pay less sometimes, but potentially so as it's not overprescribed. There are cases where there might be someone that's doing too many procedures that you really don't need to do. Are they necessary for the patient? Who's the expert in the space? Is it the insurance agency or the physician? Who's the one who is that is facing the patient? Who is the one interacting with the patient? Who knows what the patient truly needs more so, the provider or the payer? I'm not going to answer that for you. I want you to think about it. But that can be a back and forth. And so oftentimes a request from the system goes out to the payer that is, I need to do this procedure. Here's the background information. And then there might be a rebuttal that says, or a denial that says, yeah, no, that doesn't qualify for this procedure. And then what happens then? Well, a lot of time is spent to review the chart, add additional information, send a rebuttal to say, well, actually, I disagree. It's actually this and this and this, and this is why we actually need it. Okay, now you're good to go. Now you can go ahead and do it. That can take a lot of time. That can take a lot of effort, especially clinical time, because the clinician needs to actually review some of these things sometimes. It's painful. And so doing a lot of automation in this space is something that we are actively pursuing. This is something that truly helps reduce a lot of that, behind the scenes burden. One of the things that many don't think about is, what does a day-to-day look like for a physician? Many of us have this picture in our heads of, a doctor goes and sees you for 5 or 10 minutes and then afterwards goes and plays golf for the rest of the day, right? How many of you have that kind of mental picture sometimes? I can assure you that the good doctors don't do that. The good doctors, they have an entire full docket of patients throughout the day. They start early in the morning, they finish in the afternoon for just seeing the patients themselves. But then what happens next? Well, they go home, they have dinner, they change into pajamas, and you know what they do? Just like what everybody else does. They get back on their computers and they continue working. Because an action for after a visit is not just simply, are you done with that patient and that's it? There is an amount of different work that needs to happen to document and chart what actually happened in that visit. Oftentimes that happens after the working day is already over, because once again, their schedule is usually back-to-back-to-back meetings. I always complain about I have too many meetings, but physicians, that's literally every time there's an appointment, that's back-to-back meetings with that patient, right? So you see the patient, you talk to the patient, you're working through with the patient. but then you also need to write up essentially an essay every single time of what actually happened, all your notes. And so we're looking at reducing what is referred to as pajama time for the reason I just described. They go home, they're in their pajamas, they're continuing to work. We want to reduce that. We don't want physicians having to spend many, many hours late at night coding up something that happened early in the morning. We want that to be as streamlined as possible. So we're working with our Microsoft partners on a solution that it's called DAX, is what it's called. And so that's part of their nuance ecosystem, where the physician walks in the room. But let me rewind a little bit. What does a typical physician visit look like? You walk in, you sit down, the physician walks in, logs onto the computer, and then they start typing on the computer, right? They're looking at the chart on the computer. They ask you a question, they go back to typing. Ask you a question, go back to typing. It's not a very human experience. That's very much a computer experience, that they are typing up answers back to back. You don't want that. What you want is a face-to-face experience with your physician. So physician in the room takes out their phone, puts it on the counter, pushes a button, it's recording. It's now listening to your conversation. Much like this session right here is recorded, this is in a clinical setting. It's recording the conversation between the patient and physician with consent, right? We don't do things secretly. We don't record conversations secretly. But the patient says, yeah, I'm okay with this recording being done. But what happens next? This solution then takes that conversation, collapses it into a summary of here's what actually was discussed. Here are the problem statements that were discussed. Here are the orders that were discussed placing. Here are the medications that were discussed as well. Gives the physician that insight of this is all that happened here. Do you approve this? Go ahead and submit this into the chart. Instead of having to have them go back and think through, we talked about doing an echocardiogram, we talked about doing a stress test, and we talked about doing, what else did we talk about doing? We talked about doing that thing as well, right? Not having to memorize those things or remember those things, but you have that already summarized and the specific action items already provided to you. That's ambient listening. That's voice-based charting from that standpoint. So it creates that chart record, that note, gives it to the clinician to put into the record, automates that process end to end. How much time does that save? Just that by itself. And so at Wellstar, at this point, we have enabled this capability for every single ambulatory physician. So every single one now has this capability to be able to have this kind of voice charting, voice recording, and it is absolutely amazing. Some of the physicians that I talk to come back to me and go, this is just a game changer, absolute game changer. And it's getting better every day. Next steps are it will start to be able to trigger more downstream events, be able to be a little more accurate for very specialized capabilities. Inpatient is a very different kind of charting than an outpatient is. And so inpatient, that's the next step of the equation, is making that kind of automation within that space. And then also nursing. We have, I don't remember the exact number, but somewhere around 10,000 nurses within Wellstar. Every single one of them can benefit from something of the sort, where the interactions they have with their patients be able to have that kind of charting, that kind of assistance for them. One of the last items that I'm going to talk about here, and then I want to hear from you all, is automated answers. And this one is a little bit contentious sometimes. And what I mean by that is this. How many of you are able to go into your patient portal, with MyChart or something of the sort, where you can send a message to your physician? Patients love this. I love being able to send a message to my doc and ask a question. Hey, I just tested positive for the flu, and I take this other medication. Is it okay for me to still take it, or should I come see you? Or I'm concerned, I'm worried. Give me an answer, right? Or I just finished this medication, or I lost this bottle. Can I get a refill? Some of these questions, the vast majority of questions, are pretty simple, pretty basic questions. But the patient needs to be heard because the patient deserves to be heard. We want the patient to be heard. For a physician side, it can be pretty overwhelming. The number of patients that a single physician has, tremendous number. And so if more and more patients are messaging physicians, it takes up a lot of time, a lot of effort to go through these messages and be able to provide good responses. So we're looking at using Gen AI within the actual clinical systems to automatically draft potential responses. We're not automatically responding to the patient. We're not simply dismissing the patient's request and giving them a generic response. We're automatically drafting an answer, giving it to the physician and saying, is this the appropriate answer? And the physician takes it and adjusts it, changes it. So that once again, they're not starting at zero. They're starting at a good foundation, and they're able to respond more accurately to the patient. Or maybe the language needs to be more specialized to the individual patient, where maybe the patient is elderly and needs a certain kind of communication, certain kind of information, or the patient is nervous, and so more reassuring language versus someone who's a younger patient who might not be experienced in some of these areas. How do we make sure that we deliver information to the parent of a child who is having a problem? And so how do we reassure them properly, but have the right framing, the right language to express that to the patient, to the parent of the patient? All those different things are factored in. And so we're trying to automate some of these flows. And so what does it all do? At the end of the day, all these different things, all these different capabilities, they all create a more human experience. Because when you take away the physician having to keep typing on a computer the whole time, when you take away having to spend a whole bunch of time afterwards trying to think back what happened and just simply automating these processes, when you create ways for the patient to be able to get the care they need when they need it without having to pick up a phone, those are all ways to reduce the amount of in-your-face technology that you're having to absorb every single day. And it ends up creating that more human-like experience. Any questions?
All right. Thank you, Nick. That was great. I learned a lot about different ways that AI is being used that I hadn't really thought of before. So I think that's good. And I think it's all really interesting. And I do agree that, if you can make it easier for doctors, they're not going to get burned out as quickly. If you can make it easier for patients, they're going to be more involved and more willing to participate in their own healthcare, all of those things. Does anyone have a question? You can put it in the chat or you can raise your hand. We have about 5 more minutes. But if while you do that, I might ask another question. Are you all doing anything with genomic data right now when you're looking at doing prediction for patients and their care?
We're starting to, we are looking at a few things there. I don't really have a specific project to really talk through in that space, but especially in oncology domain, genomics really plays a major factor. But what I talked about with disease prediction, genomics is definitely a major contributor to that. One of the difficulties with genomics is when we're dealing with some of these models, we want to use de-identified data wherever possible, wherever feasibly possible. Whenever we send information to a third party of some sort, we want to be safe with it. We don't want to expose patient records and charts. So we try to de-identify things to send to get processed and whatnot. By its nature, genomics cannot be de-identified.
Yes, I know. Yeah, it's a problem. It is you. It represents you as an individual.
Exactly.
Yeah. Yeah, I do think though that analysis of the genome is going to help us tremendously with the care of patients as we continue to move forward. Like you said, in prediction, and you even talked about at some point about knowing what's right for that patient to reduce alarms, I think. It's the same kind of thing, right? Like what's normal for that patient? What can you expect to work for that patient or not work for that patient? So yes, definitely in the predictive analytics area. What about, you talked about some surgical augmentation and like getting the information to the surgeons while they're doing surgery to assist them. Does that is that also using augmented reality? Like, are they receiving things or is it just on more screens in the room?
Right now, it's on more screens. We've talked about using it more augmented reality. We haven't gotten to that point yet. In conversations with Microsoft, I had the opportunity to go visit one of their innovation centers recently. And they were showing some of the demos in the space where, especially in the space of training and education, And having
Yeah.
that, the augmented reality, you're doing surgery or you're looking at problem space, how can you tell what to do, right? Think of it as fixing a car engine. Well, what part do you tweak? What part do you adjust? One of the things that we had discussed at that point that I found interesting was a lot of their clients are saying, we don't want to spend too much money on the headsets for augmented reality because they can be pricey. Can you put it all into a mobile app? So can your phone be that augmented reality instead? Because everyone has a phone, right? Just about everyone, especially in a clinical setting, has some sort of device. And so trying to do that a little more handheld in that regard, just because the cost of it is something we're very cognizant of. We
Yeah.
are a nonprofit healthcare system. We don't have all the dollars in the world. We don't have a giant endowment or anything of the sort. So we are very conscientious about how we spend dollars, because every dollar goes really back into providing services, providing care to our patients.
That's great. We do have some questions in the chat. So does Wellstar utilize their own data for model training with external vendors?
The simple answer is yes, but. And what I mean by that is when we are introducing third-party models, the external vendor models, and those models require training, one of the things that we restrict is we don't give our patient data to that third party for them to use elsewhere for something else.
Yeah.
Our patient data is our patient data. Our patients, we're very cognizant about what that data really is, what it means to them. And so we don't share your patient data with someone else. We don't sell data. We don't give away data of that sort. We're very conscientious about where that data ends up. More often than not, what we end up doing is we take those models and we put them on our systems, and we train those models with our data, or fine tune those models with our data within our systems so that it stays within our virtual four walls.
Great. And then there's an add-on question. Does HIPAA compliance limit the use of AI for patient analysis?
Absolutely. Compliance is one of these things where it puts a lot of guardrails on things. Some of these guardrails we might complain and whine about. I mean, that's just that natural human element. But there's a lot of good reason for a lot of these guardrails, and we are very, very conscientious about these things. First and foremost, in that space is HIPAA compliance is a must. There's no ifs, ands, or buts. There's no, well, we'll just lightly violate it. No, 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 no. That's not an option.
Right.
So consent especially is very important. Also, it's we don't want to just simply take every single patient, run them through things without them knowing what's going on, right? We want to make sure that we're gathering consent. We realize that, well, we want to make sure that patients understand what happens when they are part of our ecosystem. That the data that we are using, when we are using their data to run through models, we do so for their benefit. It's to help them, to serve them. That's really the true intent for these things.
Yeah, great. Well, we are at time today, and there is one more question, though, if you want to answer it. Any medical imaging related AI initiatives?
Oh, how many hours do you have?
Yeah.
That's a fantastic question, because we are actively right now implementing a system that is able to run numerous different models on top of imaging data. So CT scans, MRIs, X-rays, you name it. And the idea behind it is you go in for a certain scan. Maybe you are at risk for pneumonia and you go and get an X-ray done, right? Very simple, very basic kind of thing. You get an X-ray of your lungs. And so the physician ordered that specific X-ray for checking your lungs for pneumonia, but maybe there's something else present that they did not know about. So we're using AI models to then scan these same images for other things that were not prescribed, and then be able to notify you and work with you to say, hey, by the way, let's get that checked out as well.
Yes, we've talked before about that, how you can miss things in a scan because you're looking at for something that happened in an auto accident, and so you miss something else over here, but the AI doesn't miss it. It sees everything and it pays attention to everything. So I think that is interesting. All right, so we are at time now. Thank you so much for joining us today. I think that was a great talk. I really enjoyed it and learned some things, which is always great. And I love the questions that were asked afterwards, but we'll be excited to have you back sometime, Nick. Glad to have you here.
Thank you so much, Leanne. Truly appreciate it. And